Chairman, ladies and gentlemen, good morning. First of all, I would like to say that at the moment there are no level 1 evidence studies to guide the evaluation and treatment of suspected acute mesenteric ischemia. There are at least two reasons for that. First, that acute mesenteric ischemia has low incidence, and the second reason is that there is constant evaluation of the methods, therapeutic methods. Therefore, it is very difficult to conduct large-scale randomized controlled trials. Therefore, the guidelines which I am going to present here are based on level 2 and level 3 studies, results which were published in the last 5 years, and on the guidelines which were prepared by vascular surgical societies in the last 3 and 4 years. What is very important in the management of patients with acute mesenteric ischemia is in that interdisciplinary approach. It is very important when those various specialists are working together, which is interventional radiologist, vascular surgeon, general surgeon, gastroenterologist, and intensive care physician. This allows to achieve faster treatment and, in consequence, lower mortality. Time window. Time window is very important. Looking on the literature, it looks that optimal is 12 hours. So optimal is if within 12 hours from the onset of symptoms, from diagnosis should be achieved and revascularization performed. As it was already said here, acute mesenteric ischemia has no specific clinical signs and symptoms. So it is stressed that severe abdominal pain, which is out of proportion to physical examination findings, should be assumed to be an AMI. There are no specific laboratory tests also for the early detection of acute mesenteric ischemia, because even serum lactate level should not be used for diagnosis, because normal serum lactate level does not exclude AMI. There are also, looking on other specific symptoms beside laboratory tests and clinical presentation, the most sensitive are radiological tools, and the most sensitive and specific diagnostic tool is MDCT. So it is recommended that in cases of suspected AMI, multi-detector computerized tomography scanning with intravenous contrast should be performed as soon as possible. These are results of MDCT which determine the choice of treatment. It is recommended that when bowel integrity has not been compromised, endovascular techniques should be performed as the first-line treatment. However, the presence of bowel ischemia or necrosis and perforation necessitates immediate surgical repair and resection of non-viable bowel. The decision to introduce endovascular treatment depends on the experience of interventional radiologists and on available sources in the center where the patient is treated. So, according to etiology of acute mesenteric ischemia, catheter-directed thrombectomy and or thrombolysis or infusion of vasodilatators should be applied. Angioplasty or placement of a stent in the stenosis segment of SMA should be considered as a complementary treatment. However, if endovascular therapy is not possible or clinical condition does not improve after endovascular therapy, open surgery should be performed. Surgical options to restore perfusion include embolectomy, endarterectomy, and arterial bypass graft placement. It is important to remember that even restoration of perfusion does not exclude the development of intestinal wall complications. So even after successful treatment, on-demand control laparotomy or laparoscopy should be considered. Patients who experience acute mesenteric ischemia should be followed up, and it is recommended a lifelong repeated assessment of vascular patency. Duplex ultrasound is advised to be performed every 6 months for the first year and then yearly after. Thank you very much.